First of all, I want to acknowledge my co-authors, Ritika Chaturvedi and Kira Burdit, USC and U of Michigan. And I also want to acknowledge a larger team of researchers working on this project, and particularly survey experts, Fred Conrad and Florian Kirsch, who have helped a lot with the design of this project. So a little bit of background. This project focuses on caregivers and is one of the projects in the landscape of the UAS. There is a large literature looking at whether the well-being of caregivers is different from the one of non-caregivers, but for the most part, these studies rely on retrospective data. They would ask questions about feelings or health circumstances in the past months or past 3 months or past year. But little has been done to capture the daily experiences of caregivers, which, if they accumulate over time, they become a really important driver of both physical and psychological well-being. So this is what we are trying to do with this study by combining different modes of data collection, which I will tell you shortly. There is also little understanding about how these daily experiences vary by age, type of relationship between the caregiver and the care recipient, and the type of condition of the care recipient. The project is called UAS CLEAR, and CLEAR stands for Caregiving Life Course Experiences Assessed in Real Time. What we're trying to do is to build a representative life course sample of caregivers, which we will follow over time for 2 waves of data collection. When I say life course, I mean that we would like to have a wide age range in the sample, basically covering people as young as 18 and as older as it comes. The reason being, we want to differentiate ourselves from existing studies that mainly focus on caregivers of older adults. And especially if you think of caregivers being, for the most part, spouses, then you end up with a sample that is much older than the population. So the main methodological innovation of this project is the combination of 3 types of data that will be collected. First of all, online surveys. We will do annual and quarterly surveys. We will do ecological momentarily assessment, so each respondent will participate for an entire week, and they will answer short surveys randomly over the course of the day 5 times. And we ask questions about how they are feeling, what they are doing, and who they are interacting with in the moment. On top of that, we provide Fitbits to all participants. So we will collect physical activity and other metrics of Fitbits, including heart rate and heart rate variability that can be proxy for stress, basically in continuous time. Let me jump to this slide because it explains very clearly what we are doing. So first of all, we screen caregivers using the general UAS monthly survey. So we did this from September to December 2024. We identified 2,500 caregivers. That is roughly 17% of the population. And then once a caregiver is identified, we invite them to take the baseline survey. And as you can see, the response rate was really amazing, 97%. And among these 2,400 people who answered the baseline survey, about 2,000 were eligible, meaning they had a smartphone and a data plan compatible with our app for the EMA. So among the 2,000 people, 1,400 consented. And as you can see here at the top, I don't know if I can show it. No, it doesn't, the pointer doesn't work. But anyway, the mean age is 51, but the age range is really wide. It goes from 19 to 90. As I mentioned, we provide Fitbit to people who need it. This is in line with the American Lifetime in Real Time project that Ritika Chaturvedi is running in the UAS. We think it's very important to provide the Fitbit to people in order to break the selectivity that you get inherently if you invite people who already own a device. At the same time, we also allow people who want to use their own device to come on board. And we are oversampling caregivers who help patients with dementia because we are interested in doing a comparison between dementia and non-dementia caregivers. Now, Where are we in the recruitment process? We are currently shipping Fitbit, so I won't have the Fitbit data to show you, but I'm going to focus on basically the comparison of consenters and non-consenters to tell you a little bit about the selectivity of who came on board in this project. I know after telling you about all these incredible data that we want to collect, this is probably the least interesting part, but I think there are nice surprises that you will see. So the first analysis is basically the demographic composition. The graph on the top left is the fraction of females between consenters and non-consenters. The consenters are the green, the non-consenters the orange. Not surprisingly, female are more likely to consent. What is surprising, that's the graph top right, is that white people are less likely to consent, and the main difference here is driven by blacks being more likely to consent. And another thing, a pattern that we observe, that's the graph at the bottom right, is bottom left, sorry, a very steep age gradient. So older individuals are significantly less likely to consent. What is interesting and surprising somehow is that low educated people, especially people with high school or less, are more likely to consent. Now, if you put all these in multivariate regressions, all these differences remain significant. And if you want to put some numbers, you see that female caregivers are 9 percentage points more likely to consent. Blacks are 10 percentage points more likely to consent than whites. We know other differences by race or ethnicity. The consent rate, as I said, is monotonically decreasing with age, and the largest difference is between 18 and 39 and 60 plus, and it's 19 percentage points. And college graduates are 5 percentage points less likely to consent than non-college graduates. Now, let me move to measures that are related to caregiving. Here, we show the relationship of the care recipient to the caregiver. As you can see, there's a wide spectrum of relationships and no major differences here. If anything, you see that caregivers who consent are more likely to be parents and less likely to be spouses. That's because they are younger, as I showed you before. There's also a wide range of conditions of the care recipient. As I mentioned, we are particularly interested in dementia caregivers. If you look at this graph, there are some significant differences unconditional. One of them is the difference between consenters and non-consenters among dementia caregivers, with dementia caregivers being slightly less likely to consent. But when you control for other demographics, this difference disappears. Length of caregiving responsibilities, for the most part, our caregivers have been caregivers for 1 to 3 years, but you have a wide range of experiences, and there are no significant differences between consenters and non-consenters. And one result that is surprising, we ask caregivers if they are the only caregiver or they share caregiving responsibilities. And surprisingly, consenters are 8 percentage points more likely to be the only caregiver. We were thinking about the opposite, that those with those who are the only caregivers have more responsibility, and because of that, they would be less likely to participate in a study like this. And now it's a series of really surprising results, because we can take different measures of mental health, stress, loneliness from the general monthly surveys of the US and show differences between consenters and non-consenters. I'm starting with the Poor Mental Health Index. This is based on the PHQ-4 categories. You see none means no symptoms of poor mental health, or you may have mild, moderate, or severe. And the results, even controlling for demographics, show that relative to caregivers without poor mental health symptoms, those with mild, moderate, or severe symptoms are significantly more likely to consent. Similarly, for stress, compared to those with no stress symptoms, those with mild, moderate, or severe symptoms are between 8 and 17 percentage points more likely to consent. If you look at loneliness and how frequently people feel lonely, you see that relative to caregivers who never or rarely feel lonely, those who experience this feeling more frequently are between 6 and 11 percentage points more likely to consent. And finally, those who consent are also more likely to be in fair or poor health rather than in excellent or very good health. So in conclusion, demographic groups that are often underrepresented in population studies because they tend to exhibit lower participation rates actually showed higher consent rates. And I'm referring particularly to low educated people and racial minorities. We still observe this clear age pattern that was already observed in Alire. Older adults are less likely to consent and more reluctant to come on board, especially we think when a device is involved in the project. And most importantly, caregivers who experience greater physical and psychological burden showed significantly higher consent rates. I think that this is very important because it means that we will be dealing with a sample of people where the caregiver experience really gives or may lead to outcomes that the actual outcomes we want to study in terms of burden. Thank you.